So, hello everyone. It's my pleasure to welcome you for our third webinar for the European Webinar Awards. And thanks so much for Professor Dr. Tadej for accepting our invitation. I'm really sorry for pronouncing your name not so best.
No problem.
Thank you so much for accepting our invitation and for sharing the success of our webinar. So truly appreciate it, and I know how busy you are. I know how your time is very, very hard to manage, even 5 minutes for us, but you always help them to students. So on behalf of IADS, I really would like to thank you so much. And I would like to give the floor for Yana, our school secretary, to start the
Okay, perfect. Thank you, Mariam. Thank you, Mariam, for the introduction. So, hello, everyone. Welcome to another European webinar today. I'm Jana Panachova. I'm the General Secretary of SCORE Committee, and I'm really grateful that I can see many of you again today. So, I would like to give the floor to our webinar coordinator, Mahinar, so we can start very soon. Thank you.
And thank you, Yana. So to start off with, Mahinar Gadullah, I'm the webinar coordinator of the SCORE committee of IADS. I'm very honored and very thrilled and excited, to be honest, with our webinar today with Professor Dr. Tadej. Honestly, it's been a long journey to come here, but I can't wait for this webinar, and I have to thank Professor, honestly, thank you very, very much for accepting our invitation and for taking out of your time to really come here and to help us all as students and even early fresh grads with all your up-to-date information and techniques. So I can't wait to learn from you, truly. Thank you very, very much. Our title today for our presentation by the professor is the oral cancer from diagnosis to treatment. And this topic, I know that everyone has been eager, and a lot of requests came for this in the previous feedback forms. So I am happy to say that we made it, and we made it with a great professor to be able to bring this topic to all of you. So today we have Professor Dr. Tadej Peter Dovsak. Is that right?
That's right.
He graduated in 2002 from the Faculty of Medicine and the University of Louvain, and completed the residency program at the Department of the Oral and Maxillofacial Surgery in 2019. In 2016, he graduated also from the Faculty of Dental Medicine and in the University of Ljubljana. Why am I right? Ljubljana. His main field of interest has always been oncology, surgery, and microvascular reconstructions, facial trauma, and implantology. During his residency, he was rewarded with a Hugo Obsbag grant for oncology training with Professor Vergan in Zagreb. That's amazing. Honestly, doctor, what a resume. What a reward, honestly. In 2019, he successfully defended his PhD thesis on changes of the immune status in oral cancer patients during treatment. Since 2019, he has been employed at the Department of Maxillofacial and Oral Surgery, Ljubljana, the National Reference Center for Facial Trauma, and one of the 3 head and neck centers in Slovenia, where he is currently the head of department. So it's honestly an honor, huge honor to be able to have you here with us in IADS, doctor. And I'll leave you the floor, and thank you very, very much. And guys, please, any questions you have please write them up in the chat box, and don't forget the feedback form we'll send at the end to get your certificate of participation. So here we go. Let's start.
Okay. Okay. Okay, so thanks again from all of the organizers of this webinar. It's a pleasure to be here. So either in person in the Congress in Ljubljana in September, or right now over the webinar. So my name is Tadej Dovsak. Yes, I really know it's hard to pronounce it for the other speakers, but nonetheless, let's start. So oral cancer still remains a lethal and deforming disease despite of all advances in the therapeutic management. And so I'm really glad to give you some thorough overview of how we manage everything on our department. So everything you will see is actually are our pictures, our patients, and they've been constant with that they can be shown and their identity is hidden as much as it's possible. So hope this works. Okay, it works. I have no potential conflict of interest. First of all, let's put the maxillofacial surgery on the field. So the maxillofacial surgeons, we work with the head and neck region, and so this is going to be the first thing to do, and then we'll discuss something about head and neck tumors. I'll give a quick overview of some premalignant lesions. I'll talk about the anatomy, really short, and then I'll try to focus on the oral cancer by the epidemiology, how it grows, how it metastases, and then I'll talk about the diagnostic and all the diagnostics and how we present the patients to the multidisciplinary board. I'll talk about the treatment decisions we have to make, and I'll try to go also through some complications of treatment, at least the most common one, and then the most difficult question, what to do with the teeth, and then I'll try to sum it up in some of the conclusions. So buckle up, it's gonna be a bloody ride. Okay, so maxillofacial surgery is dealing with tumors in head and neck region, and we come in conflict with the ENT, oncology. That means we work in hand with hand. So also with dental medicine, plastic surgeons, general surgeons, neurosurgeons, ophthalmologists. So we all work together, and there's a lot of work for all of us. So I don't think that you should be really concerned about who's doing what, as long as they know what they're doing. So tumors of the oral cavity are just a small, but nonetheless numerous part of the head and neck tumors. And there you have also the oropharyngeal tumors, tumors of salivary glands, so on and so on. And we can always talk about the primary tumors. We can talk the metastasis inside the head and in the head and neck region, or we can talk the lesions in the head and neck regions in the course of systemic disease. So today I'll talk about the primary tumors. Okay. What's the use of talking that to the dentist? So what's the role of dentists in managing patients with oral carcinoma? As we see it, it's irreplaceable. So the dentists are the first line of defense of seeing the patient and sending them to us. So around 70% of our patients are sent to us by the dentist. So it's the early recognition. Then it's preparing the patient to treatment. So you have to make a dental plan. Of course, we also make a dental plan, and then you follow it. You will see later on. So we decide together with you which teeth we should keep, and you should make the restorative treatment of the teeth that will be kept, and extract the teeth with bad prognosis. Although usually the surgeons do that, but nonetheless. And then it's also the follow-up and restorative treatment after the therapy. You will see there's a lot you'll have to do, at least by the new guidelines. And there's a fluoride treatment. And for all of that, you should know the basic principles of treatment and the consequences of given treatment, which is actually the idea of this lecture. So what is a suspicious lesion? Where your alarm should go off? So anything that has a change in either color, texture, level, firmness, and it's growing and it's invading the surrounding tissue. So if you should remember anything out of this lecture, it should be that anything that does not go away in 2 to 3 weeks after removing what you think that might be a possible cause of a lesion, take the biopsy or send for the biopsy. And if it looks suspicious and the biopsy is negative, repeat the biopsy. Okay, coma, etc. So if you remember anything that, and just one thing, this would be the most basic and important one. So normal mucosa is pink, soft, and moist. And if something is not looking like that, and it's when you feel it, it's not soft, then think of what might be the reason for that. So we also have the potentially malignant disorder. There's a whole list of it, and actually the prevalence in a global area is around 5% of population will have them. I'll just talk something about leukoplakia and erythroplakia. So we have the white patches and the red patches. So if we look at the white patches like leukoplakia, like here, you can see that this one is not really homogeneous, nice, thin, but it's thick. In some area, it's already red. And this one definitely deserves the biopsy from this middle area where the white, red, and the normal mucosa meets. So the rate of malignant transformation of leukoplakia is around 3% if it's homogeneous. But once it's got a lot of degree of dysplasia, it can get up to 30%. While on the other hand, if we look at the erythroplakia here, this is, at least by the literature, the malignant transformation is over 50%, but in our hands, we already count this as a carcinoma inside of it. So we always remove it like that. And based on the evidence that it's now recommended in the last studies in the last year, all high-risk lesions should be excised in the absence of any surgical contraindications. While if you have like homogeneous leukoplakia like this, you take the biopsy, you see that there are no atypias or dysplasias inside, you can easily remove it with the laser and leave it to heal by the secondary intention. Okay, now let's slowly move into the oral cancer. So you all know the anatomy. So the subsites inside the mouth include the oral tongue, have it here, and then you have the floor of the mouth, you have the buccal mucosa, you have the vestibular mucosa, and then you have the hard palate, and you have the retromolar trigonon. And that's it. That's oral cavity. So today, I'll talk about the squamous cell carcinoma. Why? Because it forms more than 90% of head and neck malignancy. So although head and neck malignancies present around 3% of all malignancies, the other 10% that you're going to find inside the mouth are going to be something dealing with the salivary glands, either going to be lymphomas, sarcomas, sometimes really rarely malignant odontogenic tumors, but most of the time we are dealing with squamous cell carcinoma. Slovenia has a population of 2 million. So that means that our numbers are really low. The whole incidence of head and neck cancer in Slovenia is around 400 to 450 patients per year. And to the oral cavity, that counts around 120 patients. There are 3 centers in Slovenia dealing with the oral cancer. It's our in Ljubljana, and then we have the ENT center in Maribor and also in Ljubljana. We do around 80 patients per year and the rest of the patients are divided between ENT departments. So the etiology of oral cancer is mainly smoking, alcohol, and in some Asian countries, betel nut. And there's also been studies showing that self-neglections, poor oral hygiene, and low socioeconomical status and poor diet fall on the are accounted on even on the statistics that are not connected with the alcohol and smoking, although this is really hard to separate. And here you can see that I crossed the virus. So human papilloma virus does not play a role in oral cancer. It does play a huge role in oropharyngeal cancer, where in some countries in the world, actually oropharyngeal cancer is becoming the sexually transmitted disease. And if we're talking about the oral cancer, the HPV infection does not play a role and thus have no impact on survival. Although you can confirm it in around 3 to 5% of cases, it doesn't have any role so far. What's the typical patient with the oral carcinoma? So the male versus female incidence is 3 to 1. And it's usually patient over 55, smoker, drinker, with poor oral hygiene and bad dietary habits. So that's pretty much the 95% of our patients. And then you still have the 5% that don't fall into that basket, but it's always like that in medicine. So what are the clinical signs of oral cancer? The problem with them is that they are uncharacteristic. That means it might be some difficult swallowing, or patients might see that their teeth have become mobile, or their dentures are not fitting the same as they did a few months ago, or they might have a foul breath. And pain becomes evident late in the course of disease, while the tumor reaches well-innervated tissues. And this is all how it looks on first presentation. So we might have some small ones, bigger ones, and it's hard to imagine why patients wait so long, but that's the paradox of the oral cancer. We'll talk about that in a few slides. So what's the natural course of disease? We have the tumor on the left side of the tongue. You see it here, pretty clear look. And then you can see how it spreads. First, it spreads with a local spread. So it's moving around the tongue, it's creeping around the muscle, down, it goes over the mylohyoid, or it goes to the periosteum. And if it grows long enough, it will go through the periosteum and inside the bone. So that first is the local spread. And then we have the regional spread. So the oral cancer spreads by the lymphatic spread. That means that it spreads to the lymphatics on the neck. And in the neck, we have around 300 lymph nodes. Remember, that's 1/3 of all the lymph nodes in the body. So you all know the neck regions. You have 6 regions. The 6th one is the anterior region, and the ones that are commonly dealt with in oral cancer are the ones from 1 to 5. And then if it grows long enough and it goes into the circulation, the patients can develop distant metastases. Distant metastases in oral cancer develop in around 10 to 15% of cases, and they mostly develop in first 12 months, and practically all of them up to the 2 years. And 20% of patients will have the local regional control, while 80% of patients, so majority of them, will have some kind of failure, either local or regional, or they might get a new tumor, and it's really hard to say if it's a new or it's actually a progress of the old one. And the median survival rate with a distant metastasis is really low. It's around 6 months. The most common sites are lungs, liver, and bones. It's really unusual to get a patient with distant metastasis that has distant metastasis, either liver and bones, and doesn't have them in the lungs. So we usually check the lungs for the distant metastasis. So this is how it goes. So we have the tumor, and it metastasis lymphatic to the neck, and then if it grows on and on, you get a distant metastasis. You also have this possibility where we don't see the regional metastasis, but it is really, 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 really rare. And then we have to follow up the patients. Why? Because we are looking for the recurrence, and we are looking for the secondary tumors. You know, if the tumors arose because of the smoking and drinking, so the same cancerogenic environment was all over the upper aerodigestive tract. That means that there is no reason why you get a tumor inside the oral cavity and don't get it a little bit later in the hypopharynx, larynx, oropharynx. So you have to follow these patients thoroughly. And we get 95% of recurrences in the first 2 years. And because of what I said about the cancerogenic influence inside the upper aerodigestive tract, 3 to 5% of patients will get the secondary tumors. And this is the patient when that was the first year of my employment as a resident on our department, and this guy presented with lingual carcinoma on the right side, and that's him 11 years later after we did a laryngectomy for his third tumor, and that's how we communicated after that laryngectomy. So it says, everything is as it was, I feel okay, I can manage my weight, and I don't have any problems with feeding. Unfortunately, the guy died because of the fourth cancer that was inside the lungs 3 years later. So if you see that 95% of recurrences happens in first 2 years, and then we have most of the distant metastases we find are going to be evident in first 2 years. That means that we have to follow this patient closely, especially in these first 2 years, to maybe find a time where we can still help them. And in the first 2 years, we usually follow them to 1 to 3 months, and then third, fourth year, every 3 to 6 months, and then after fifth year, we follow them once per year, and we usually stop following them after 7, 10 years, depending on how much patients want to come to us. And usually they like to come for a checkup, and if we can still manage it with our time, we still do it. 80% of oral carcinoma arises on 20% of oral cavity surface. That means if you're just gonna look inside this horseshoe-shaped area, which is also called the pool of saliva, that's the floor of the mouth, the lateral and ventral surface of the tongue, the retromolar triangle, and the lower alveolar regions. And if you put your fingers in and you go around this area and feel if everything is nice and smooth, if there are no edges that might get your attention, even if you don't see anything. So look and palpate. And with this only, you can spot 80% of oral cancers. So why are there like 60% of patients coming in an advanced stage of presentation? What this means, that's the paradox of oral cancer. Advanced stage means that either the tumor is bigger than 4 centimeters, that it's thicker than 10 millimeters, or it already has a nodal metastasis. So something that it's unimaginable for somebody that already had something inside the mouth. But remember again, that pain comes really, really late. Yeah. So why is that so? Well, one study showed that more than 50% of patients did not have an appointment with the dentist in the last 5 years. Or let's say only 1/3 of medical practitioners performed an intraoral examination as a routine. So something alarming. Or like I said, 70% of patients are referred to us by you dentists, and 500,000 people, so that means 1/4 of a population of Slovenia, does not have an assigned dentist. Does not have an assigned dentist in a public health system, but still, if we took roughly that half of them are going to a dentist in a private practice, there's still 250,000 people that are not being regularly seen by a dentist. And that means that they will go to a doctor or a dentist when the pain is present, which is already, as seen, late. So look inside the mouth every time you have the patient and refer to biopsy if something does not go away in 3 weeks. So once the patient walks in the clinic with a suspected lesion, we take the biopsy, or already the biopsy was taken somewhere else and we already have the diagnosis. If we take the biopsy, we explain to the patient that we're going to get the results 1 week later and we reschedule him, but we still do the thorough physical examination. So the physical examination should have a thorough, clear description of the tumor, its size, use the millimeters, please, either its borders to the neighboring tissues, and especially palpation of the neck for possible neck metastasis. Why it's so important to palpate the neck? Because once we have the neck metastasis, the expected 5-year survival is lowered for half. So node metastasis lowers the expected 5-year survival almost to half of the one with the same size of tumor, but without neck metastasis. Then, when we have the positive results, we do the orthopantomogram or either CBCT, and then we do the ultrasound of the neck and abdomen. Why that? So with ultrasound of neck, it's non-invasive, cheap examination of all lymph nodes in the neck. And then with the abdomen, we screen for some secondary tumors that might be found like just with a coincidence. And then we do the CT of head and neck region with a contrast, and then we CT scan of thorax or just the plain X-ray of thorax. That's searching for the possible metastasis or some secondary tumors. And then in some special cases, we either decide for MRI or PET-CT scan, but that's individual for every patient. But as far as this goes, so orthopantomogram, ultrasound of the neck and abdomen, CT of the head and neck region, and CT scan of thorax, everybody has it with a diagnosis of oral carcinoma. And then, according to all of that, we have the clinical TNM. So you know the TNM classification allows us to group tumors in stages. So we have some characteristic that allows us to compare treatment results, survival rates, and etc. But you have to know that it's either it takes into account the tumor, so we have the size of the tumor, and then we have the nodes, either they are 1, 2, 3 positive, and they are bigger, smaller, they have the extracapsular spread or not. So I won't go into the TNM classification because you can read it up in every book. And then we have the metastasis. So we put the patient in a CTNM, and then we present it to the multidisciplinary board. But what you have to remember is that the TNM classification only takes into account the tumor characteristics, and we don't take into account the patient characteristics and also not the surgeon's characteristics, which is something that if you might start working with that, you start thinking more and more of that as well, your career goes on and on. When you present the patient on a multidisciplinary board, so it's never a surgeon and it's never a radiologist that decide, okay, we'll do the radiotherapy for this guy or we'll do the surgery for this guy. No, it's a multidisciplinary board. And it's composed of surgeon, radiotherapist, and thank God in the last 5 years, we managed to have also a dentist in our group. But in an ideal scenario, there would also be a psychologist, we would have a nutritional specialist, we would also have the pathologists who will look at the sample of the patient oral cancer later on, so he or she would know how to orient it right and where were some possible problems, but that's only in some, probably not that near future. So then we discuss the treatment plan with the patient. We explain him the possibility of surgery that might be still followed by radiotherapy and chemotherapy, or we explain the possibility of primary chemoradiotherapy, palliative radiotherapy, or palliative therapy. Depends on the patient, depends on the size of the tumor, the extent of the tumor, some possible secondary tumors. So actually on this multidisciplinary board, the patient gets the individualized treatment, which is still somehow led by the National Comprehensive Cancer Network, and we have the Slovenian guidelines that are actually just the translation of the NCCN guidelines. So if primary therapy is surgical, the patient is again presented after the final pathological report. That means when we cut all the tumor out, we cut the nodes out, we send them to the pathologists, and they look through them, they count the lymph nodes, they measure the tumor, they measure the distance of the healthy mucosa to the tumor, they measure the distance of the tumor to the bed of the cut, and they see if there are some lymph node metastases, and they write all this down. And when we get the report, we again present the patient to the multidisciplinary board, and then based on the findings, we have to decide whether it's enough if we just follow up the patient, or we go for the adjuvant radiotherapy, or the patient, because of some negative prognostic factors in the pathological report, needs an adjuvant radiotherapy with chemotherapy. In oral cancer, the best chance of survival the patient will still have if we start with surgery. Either if it's going to be the only treatment modality, or because of the tumor characteristics and nodal metastasis, it's going to be followed by the radio or chemotherapy later on. So sometimes the patient says, okay, but you explained to me you're going to remove half of the tongue, you're going to remove all the lymph nodes on the left or right, it doesn't matter. And why don't you just radiate me and the tumor will shrink from this size to this size, and then you can excise it out if there will be something left. So this tumor shrinkage pattern does not follow it in this way, but it goes in this way. That means that everywhere where the tumor was before the radiotherapy, you can have a vital tumor cell. It might be here, it might be here, it might be here, it might be here. So actually, you'll have to remove at least as much tissue later on as you had when you started, but the quality of the tissues will be a lot poorer after the radiotherapy. So let's talk about surgical treatment of oral cancer. Nonetheless, I am the surgeon. So the primary goal is R0 resection. That means resection with clear borders. Clear borders in oral carcinoma means that the tumor is removed with at least 5 millimeters of pathologically clear borders. In practice, this means cutting around 15 to 20 millimeters of at least on clinically uninvolved mucosa, but you have to do it in all dimensions. Of course, it's not sometimes possible because of bone, it's not possible because of the vessels, but think of it as a three-dimensional removal of tumor. In practice, that means cutting a finger width around the tumor. You take the tumor inside your mouth, inside your hand, and you cut around. And then we have to decide, okay, how can we remove that tumor? We have to decide about the approach. You'll see we have a lot of different approaches we can use in oral carcinoma. And then we try to keep as much as possible of the non-involved tissues, because this will help with the function and aesthetics later on. And then we have to think about the neck. So are we going to do the microvascular reconstructions, and we will need the vessels and the neck? In this case, every time we go for the vessels, we also do the neck dissection. Why? Because then we have some kind of staging. Like I said, node metastasis lowers the life expectancy for half. And then we have to decide how will we reconstruct it. We'll see we have different options. And then we have to decide either we're going to do the tracheostomy or not. This is something I'm not going to talk about because it will take us too much time, but nonetheless. And then the important thing for you is what to do with the teeth. So now look at possible approaches. So one simple oral carcinoma, here you can see it. It's like 7-8 millimeters, really shallow. That means around 1 millimeter if you feel it on fingers. That's always a problem because you get the thickness only after the final pathological report, but nonetheless, you get the filling in your fingers. So you cut around, like I said, around 15 millimeters, you do it, you remove it, and then you just simply close it back, and it functions really nice. So it would be a pleasure for us if we would always find such small carcinomas. But like we said, 60% of patients come with tumors that are either bigger than 4 centimeters, that have a nodal metastasis, or are thicker than 10 millimeters. If the tumor is not going to be controlled well enough with the intraoral excision, so then we have to decide how to cut the face to get to the tumor. And one of the possible techniques is lingual drop technique. That's the one we use if we want to remove the tumor together with the neck dissection specimen. Then we have the possibility of either dropping the lingual area with the cut inside the mouth. And you can see here, it's already also done with the marginal mandibulectomy. And then you get everything down to the neck. So this is the mandible, and this is the marginal mandibulectomy, together with the tongue, that it's just lifted under the mandible down to the neck, and then you remove the tumor, and you can see the tumor here, together with a mass of clinically non-involved tissue, and the marginal mandibulectomy, and a both-sided neck dissection. So that was moving the tongue together with the tumor, or floor of the mouth with the tongue, to the neck, where you can have a control inside your fingers. The same here, you can see a large tumor on the left side of the tongue, and you have the control inside on the neck, and you can easily remove half of the tongue, and that's the defect you can see. But sometimes we are moving the tissues away that are blocking our view, and that's the lip split and the mandibular swing. So we remove the lip. Either it's the same idea for the upper, so for the maxilla, we also split the upper lip, or we split the lower lip for the mandible, so for the lesions that are inside the lower part of the oral cavity. And you can see we move everything apart, and we have a clear view on the tumor, and we have a control on the vessels from the side because of the neck dissection, and clearly we can view the tumor and we can work around with safety. Like this, split it. You can see the jigs. We'll talk about the planning, the virtual planning. These are the jigs that we use for cutting the mandible, because it gives us the correct position where we have to do it, and we don't have to think around really much. And this is the defect you have once you end up with the removal of tumor and neck dissection. Like I said, one thing is removing the tumor, but the other thing is thinking about the neck. So the first thing where the tumor is going to go, it's going to go into the lymph node metastasis on the neck. So the arbitrary agreement is that we do the elective neck dissection when we cannot prove that the patient has a metastasis, but according to the tumor, the probability of a nodal metastasis is more than 20%. And then we have the curative neck dissection, where we already either clinically or radiologically or with a fine needle biopsy have proven that there is a nodal metastasis. And we can have we can do a radical neck dissection, which we do really rarely nowadays, or modified neck dissection, or usually we go for selective neck dissection for the levels 1 to 4, or sometimes 1 to 3. So radical neck dissections, just to give a short overview, it's like more than 100 years old. This is described by Kreil in 1906. And it's here together with the segmental resection. So with the commando, you can see that a lateral wall of pharynx is missing. You can see that there's, let's go like this. So this is the cut end of the mandible. That's the cut end of the tongue. There's the lateral pharyngeal wall missing. There's the external carotid artery that's been ligated. And that's how the radical neck dissection looks like. There's no sternocleidoid mastoid muscle. There's no internal jugular vein. You can see that it's sutured here and here. And there's no accessorious nerve. And then we have the possibility of modified neck dissection when we leave some of the non-lymphatic structures. That means we either leave the jugular vein, internal jugular vein, or we leave the sternocleidomastoid muscle, or we leave the accessorious nerve, as you see it here, or we either leave all three of them. And then we have the selective neck dissection, which is only clearing up the levels, usually for the oral carcinoma, like I said, 1 to 3, but we also usually clear up also the number 4. Okay, so we removed the tumor, we did a neck dissection if there was a reason to do it, and then we have to decide how we're going to close the defect. We can either do, we're working on the reconstruction ladder. You see it's coming from healing by a secondary intention, but I already put there nothing. You'll see why. So, and then we have healing by the secondary intention, primary closure, so on, because doing nothing is actually healing by a secondary intention, but where we close the cavities, either oral, sinal, oral nasal cavities, by some kind of prosthesis, the obturator. A good thing, but nowadays, with more and more microvascular reconstruction taking over and over, even simple cases, the obturators are seldomly used, but they still offer a really, really good way of getting around if the patient is not suitable for some big surgery. Then you have this healing by secondary intention in places where we have well vascularized tissue in the bed, so we can leave the wound to granulate. In this case, we use you can see the floor of the mouth. We remove the tumor that's seen here. We remove it with a nice margin, and then we just leave the whole thing to granulate. And sometimes we also use the prosthetic device that pushes the tongue back. And once the granulation is over, the tongue is not really pulled to the alveolar ridge, and it really makes a difference of how these patients speak if we put this device on. It's not really nice to wear it for first month, but it gives a tremendous difference in result if you put it in. Then we have the possibility of primary closure, which you already seen. Then we have some local tissues, let's say facial artery, myomucosal flap. For a defect on the palate, we chose the mucosal flap based on the posterior artery. And then you can see it here, it's already lifted up together. Then we ligate the facial artery coming from below, and then we move everything inside the new region, and this is how it looks later on. Then for the upper jaw, sometimes for bigger defects, we use let's say, like in this case, for partial maxillectomy, we use the temporal muscle. We just peel it off the bone and get it under the zygomatic arcus, and we push it inside the mouth. We suture it in, we leave it to granulate, and this is how it looks 3 months later on. But there's a hollowing on that side if you compare it to that side. So there's a minor aesthetic problem, and the patient really has to follow the exercises on so he doesn't end up with arthritis. The next regional flap, which was something that was really common, it was a common workhorse in the area before, in the time before microvascular reconstruction. It's the pectoralis major muscle flap. You can see it. We lift up the whole pectoralis major together with the skin island, and we suture it inside the mouth. And now we're getting to the microvascular reconstruction. So from 2007, we do all of our microvascular reconstructions by ourselves. Before that, we had a really good collaboration with the plastic surgeons. But then at one end, we decided that we're going to do it by ourselves. And we got Dr. Didanovic coming from Maribor, who was a really skilled microvascular surgeon, together with the ENT, being an ENT surgeon, and he also is a maxillofacial surgeon. So really, really skilled surgeon. He's the head of our microvascular team, and he said, okay, guys, we're gonna do it by ourselves. And from then on, we started gradually. Nowadays, we do around 45 microvascular flaps per year, which is based on the population of Slovenia, a lot. And you always try to reconstruct same with same, almost always. So that means if you remove the hard tissue, so the bone and the soft tissue, you try to reconstruct it with bone and soft tissue. It's not always like that, but usually. And if you only remove the soft tissue, you use the soft tissue. You can see the most commonly used soft tissue flaps and bony flaps on our department. It's the same all over the world. So we have, some of them also use the rectus abdominis. We don't use it. And we use the latissimus dorsi. It's a bit of preference of the surgeon. So from 2012, we are doing in every patient that has a bony reconstruction with osteotomies, we try to do it first virtually. And we are doing the from the computer like this. I hope it's gonna work. Yeah. So you can see, you decide where the tumor is based on the CT scans. You put the DICOM files inside the program, and you can plan the cuts. You can put in the fibula. You can put in the iliac crest, like in this case. Just a minute. So same thing as before, but we've seen that the cuts and the aesthetic results is going to be better if we put in the iliac crest and not the fibula. So we decided for the iliac crest. You can do anything on the computer, but there's a lot of knowledge going on in a surgeon's head during the planning, because one thing is doing the surgery on the computer, and the other thing is when you end up with a problem in the operating room. So it takes a lot of experience, and you gradually learn as you do mistakes. Yeah. So you can see a patient with large retromolar trigonum carcinoma already invading the mandible, and this is the planned resection. So we did the segmental resection according to the guides that we made from the computer, and then we have the guide that helps us cut the iliac crest in a correct shape. And then you can see we have the printed models of the mandible with already inserted flap, and then we pre-bend the plate, and you can see this plate already that was pre-bent before, and then we can just put it in, and you will see how it takes us 5 minutes to put in the flap. So this is real time. So you take the flap, you ligate the vessels on the iliac crest, and then you just put it on, and you already have the pre-drilled holes. It actually takes 5 minutes to have the flap in and in a correct position, just where you plan it. So let's move to radiotherapy, and I'll talk about the complications. I almost got carried away and talk about the complications now, but let's go through the radiotherapy and chemotherapy just from the sake of that you know something. So nowadays in Slovenia, all radiotherapy is done on the Oncological Institute in Ljubljana. So that means that it's centralized. Remember, 2 million people. And all the radiotherapy is done regarding the oral cancer with IMRT. So it means the intensity modulated radiation therapy, and it's done by the radiotherapist, and who signs the site, where the tumor is, or where the tumor more was, because the tumor was removed, and they have to know where the tumor was before, and then they shade the area, and then they add to this area the layers where the isodose is gonna fall down, and then the distribution of doses is such that the healthy tissues get as little as possible radiation, with the tumor bed and lymphatic bed getting the planned doses. So the whole plan is done in such a way so to spare as much as possible mandible, maxilla, large salivary glands, spine, medulla oblongata, and pharynx muscles, as much as possible. You can see that for the oral cancer, the doses are between 56 and 66 grays. And if the surgery is not gonna be the primary treatment, then it's gonna be the radiation together or not with the chemotherapy, it's gonna be the 70 grays. So if the surgery was first, the patient will never get more than 66 grays, depending on the prognostics from the pathological examination. The patient always gets a mask. Why? Because you need to have his head fixed to the table, so the tissues will be every time when you position the patient on the table on the same position. Otherwise, if you're going to move, the tissues are not going to get the same, the amount of the dose that you want to apply. Okay, chemotherapy adjuvant in high-risk patients, that means that they have the multiple positive levels of nodes. Either there was extranodal spread on the lymphatic metastasis, on the lymph node metastasis, either was microscopically not clear resection, or it had other negative prognostic factors. The chemotherapy as adjuvant treatment is always given once weekly, only to fortify the radiotherapy. So the hair is not going to fall off, and this is just something you know if the patient is going to ask you. So just tell them it's going to be once a week. They will know it. They will speak with that with the radiotherapists. And if it's the only therapy, then you have the combination of chemotherapeutic agents, and like I said, the radiotherapy is going to be the cumulative dose of 70 grays. Let's go quickly through the complications of therapy. One of them is not microscopically clear borders. I won't speak about the macroscopically not clear borders because that's poor planning. So this patient shouldn't be operated on if you have macroscopically unclear borders. But let's speak about the pathologically positive borders. That means also if the border is less than 5 millimeters, that is something that you don't want to do. And usually we go for the resection. If it was done in a large tumor and the resection is not possible, then it's something that it's meant as a negative prognostic factor for the radiotherapy, and also something that might consider giving the patient the chemotherapy. And then it's the failed flap. And I don't want to talk about inflammation and extended healing, although it's important because sometimes patients fail to go through the planned radiotherapy. The planned radiotherapy should be done within 6 weeks after the surgery. That's where the survival is best. So after 6 weeks, the survival benefit starts to fall. So its microvascular reconstruction has a success rate of 95%, which is great, but except for those 5% of patients. So if you have a failed flap, you usually have to remove it, and then you wait either for it to granulate, or if it's in the anterior region of the mandible, you might end up with endigum deformity. That's an euphemism for the anterior mandibular defect that creates the appearance of an absent chin and lower lip. And it just tells you a lot about surgeons that are taking the name from the strip character, but that's how the surgeons are. And patients with this deformity are a real risk for airway compromise, cosmetic embarrassment, excessive drooling, speech impairment. So it's not something that you try to walk in lightly. And usually, even if the first flap failed, we try to reconstruct them later on, if possible. Sometimes you get the you have the partially failed flap. Just listen to the patient. Yes. So we have removed the hard palate, the soft palate, because of large tumor, and we did a reconstruction with a radial forearm flap, or was it ALT? It doesn't matter. So with some soft tissue flap that had a partial breakdown, and because of that, the patient had a large velopharyngeal insufficiency, and either we could do another flap, or you can see inside the mouth. We just covered that with the prosthesis, the prosthetics. You can see the large defect, but the prosthetics really managed to cover it up with a nice obturator, and you can see how well the patient functioned with that. So it's not always that you have to go for a space shuttle. Sometimes with a simple stick, you can poke somebody really nice. And if we look at the complications of therapy from the radiotherapy, there's a lot of them, and we're stepping inside the teeth area right now. So this is the last thing I will talk. So I know you're already tired. Me too. So we have the early complications. It's radiodermatitis, radiomucositis, and loss of taste and xerostomia. and the xerostomia persists. Usually it might get a little better, but usually it persists, depends on the doses. But the things that we are really afraid are the post-radiotherapy caries, the inability to open the mouth, so the trismus, and the osteoradionecrosis as the most feared complication. In the sake of time, I will leave out the complications of chemotherapy, and let's just see what happens with the teeth once the patient gets the radiotherapy. So the radiotherapy causes direct damage to the tooth substance and also indirect influence because of the change in environment. And then if we get some trauma either from extraction or the pressure ulcer, we might end up, because of the damage repair and regenerative mechanisms, we might end up with the osteoradionecrosis. So osteoradionecrosis is presence of an area of exposed, devitalized bone present for greater than 3 months in an area that has been irradiated, and we don't have any sign of local neoplastic disease. And there is also where you dentists come inside the treatment. So we have to make a dental treatment plan before radiotherapy. And this is what we all do before the commencement of the treatment. And also we have to remove the teeth that you cannot save, but we have to take care of the ones you will keep. So last 5 years, we made it into the national guidelines. And that means that every patient should have a dental examination with treatment plan according to the available time frame for radiotherapy. And the idea behind that is to prevent or at least delay development of post-radiotherapy caries and its consequences. We know we won't be able to completely prevent it. We'll see later, but we still like to somehow delay it. And this is how the osteoradionecrosis looks like. So because of the ill-fitting partial prosthesis, there was an ulcer, and then it suddenly developed into osteoradionecrosis and the pathological fracture. And this is once the possibility of osteoradionecrosis rises massively after the mandibles getting, or the jaws getting more than 50 grays, and the incidence is around 2 to 5% of cases. And what is important is that in more than 80% of cases, it is provoked by extraction or ill-fitting prosthesis or either implant insertion. So we try to do everything that is possible to prevent it. So in a Slovenian recommendation from 2 years ago, we divided patients in 3 risk groups. We put them in toothless, the patients where we will remove all of the teeth because they're not worth keeping, and the ones where we will keep some teeth with clear idea that we will have to take care of their teeth after the radiotherapy. The patient will have to have a thorough instructions how to open the mouth after the surgery and during the radiotherapy to prevent the limited mouth opening that might be because of the fibrosis of the masticatory muscles, either from surgery or radiotherapy or both. And this is why we started doing that and why we put it in the guidelines. Because with no dental treatment, you can see how the patient looks 6 months and 12 months after the radiotherapy. And you cannot see how it looks 6 months after the radiotherapy with prescribed dental treatment. But you can see, sorry for that, it just got lost. But you can see that it's a clear difference how it looks 12 months after the radiotherapy with the picture on the left side. So we have 3 groups of patients. We have the toothless, where we just have to worry that the prostheses that are going to be done will be well-fitting, and there will be no pressure ulcers. And then we have the ones where we will remove all of the teeth because none of the teeth inside the mouth is worth keeping. And then we have the ones where we will keep some of the teeth, and which one. So we decided to follow the concept of the shortened dental arch. That means that we remove all of the molars. Why? Because if you try to imagine how you will do the endo treatment on the last molar, or let's say the second molar, in a patient that opens the mouth only for 2.5 centimeters because of the radiotherapy or maybe surgery, it's impossible. So we will end up with a problem later on, and you will end up with a caries on the cervical regions eventually, and then you will have to do some endo treatment, and it's impossible to do it behind the number 5. So that's why we remove all of the molars. In some patients, we decide to leave them in, but we are talking only the patients that are going to be irradiated. So if the patient is not going to be irradiated, we leave in the first molars with no problem. But if the patient is going to be irradiated, then we follow the concept of the shortened dental arch. We can discuss that in a discussion later on. I'm getting to the end. I think it's slowly 58 minutes, so I still have 2 minutes. Dental rehabilitation is something that it's really important. We managed to dentally rehabilitate around 70% of our cases, and around 15% of them receive implants. The reasons for that are numerous, and we can discuss them later on if we want. And then lastly, the survival of the patients, overall 5-year survival of the oral cancer is around 65 to 70%. The disease-specific survival is better than the overall survival, because you have to know that drinking and smoking takes a lot of out of your body. So this patient have a lot of comorbidities, and they die during the follow-up because of them. But one of the things that you have to also remember, that stage 1 has a survival of over 85 to 90% 5-year survival, and compared with only 10% survival with those diagnosed at stage 4, so the highest stage. So the sooner we find the tumor, the less morbidity the patient will have because of the surgery. Probably the surgery is going to be the only modality he's going to need for his treatment, and the survival is going to be better, and the consequences of treatment will be minor. So we have to find them soon. If you want to talk about something like that, you have to have a thorough follow-up. Otherwise, you're just either citing the studies from all over the world and you don't have your own data. So for the last more than 17 years, we have our own oncological base where we follow all our patients together with the pathohistological examinations and everything. And so we can get a easy survival curve in, let's say, half an hour of playing around with the computer. So what's the take-home message? Oral cancer is a disease with well-known etiological factors. 2/3 of a patient will present in advanced stage. Again, paradox of oral cancer. Every lesion inside the mouth that persists for more than 3 weeks after removal of possible cause should be histologically verified. The treatment is always in a tertiary specialized centers and involves multiple specialists. Follow up the patients because they will get the recurrences in first 2 years mostly, and they will have the secondary tumors and they will have the distant metastasis. And the role of dentist in the oral cancer care is really irreplaceable. So just to finish it up with actually not the joke, but nonetheless. So in which situation you would not examine and palpate oral cavity in a heavy smoker and drinker? So only in 2 cases. You have a patient that does not have a mouth, or you have a doctor dentist that does not have arms. Please look inside the mouth, palpate inside the mouth, And like I said, Shaha's rule of 20. Shaha is excellent head and neck surgeon from the Memorial Slope Gather, and he's known for his aphorism. And that's the one I really like. So I just hope that you will remember the correct 20%. There's my email if somebody wants to have a chat, something, have a question after the discussion. And that's all from me. That's our head and neck group. In the orange is Dr. Didanovic, the head of our team, and these are the younger colleagues, and you can see that we also hang around out of the operating group. Thank you very much.
Thank you very, very much, Doctor, for this, Professor, for this webinar. Honestly, the lecture has been amazing. It's very, very detailed, and I really, really love that about it, and I'm pretty sure everyone did. I mean, you really you delved into even the operations, the videos, and everything. So really, really thank you, Doctor. I personally, we only stopped until the early treatment back in uni, so to see what happens post that is very interesting, and that it's doable, it's manageable, and that it really starts from us just to really screen properly at the beginning. So thank you very, very much for this lecture, honestly, Professor. I had a question to start off with. I was wondering if with research has there been identification to genes or specific markers that could be seen early on before, even if there are oral lesions present in the the mouth? Has there been any breakthroughs in that, or there hasn't been any update or
There all the time there are actually articles coming out about the possible markers, but unfortunately it's still more on the research department. So far, at least from the common clinical use, there is not much you can do except for looking inside the mouth and putting the fingers inside the mouth. Unfortunately,
yes.
You have some of the fluorescein how it's called devices where you can light the mucosa with different wave lights, and you can see if there are some dysplastic changes, but it's expensive, it's not in everyday use, it takes a lot of time, and still fingers and eyes is the best things you can do for now. And especially because you as a dentist are the surveillance zone for our patients. So first thing is you have to get the patients coming to the dentist. That's one thing. And the other thing is you have to look inside the mouth and find something and recognize if something is
there's something present. Okay. Thank you very much, Doctor. There's another question. It was, what about using dyes for detecting dysplasia or cancer?
Yeah, that's what I said. You have the dyes where you can look under the different wave lights, and you can see. We had the machine on our department for a test. It takes really a lot of time. So if you have 30 patients daily in ambulant, it's almost impossible to work with that. But on in high volume centers where you have the trained support staff that can do it, it's manageable. So that might be something that will be in the future.
Okay, that's great. Thank you. Another question. So there's a question says, how do you decide on a method to close a defect after surgery for the best outcome? And she was the continuation was, are there any certain guidelines / rules of thumb to follow, or is the surgeon's experience and preference the most important part of the decision making?
Yeah, I mean, like I said, so the experience of a surgeon plays a huge role. And it's the same with the approaches. So first you have to start with the large approaches, so you have control under the tumor. But then once you have a certain surgeons that are really skillful, you will see that they can do things through the mouth that all of the others have to do with the lingual drop or so on, or at least as good. But as long as you think about the reconstruction, you get it tailored to the patient. That means if the patient is really not a suitable candidate for microvascular reconstruction, or he's not a good candidate, or she is not a good candidate to stay, because it takes 3 to 4 hours longer in the operating room if you have to do the microvascular reconstruction, and a lot of things can go wrong. So if he's not a good candidate to stay in general anesthesia, then it's a little bit easier decision. So it's always better if you have much more tissues inside the mouth, especially for the tongue, let's say, because the tongue is going to be better movable if you have it, half of it made out of, although non-movable tissue brought from somewhere else, but the half of it that it's still moving, it will be moving better if it's attached to something that can move around and not attached to the alveolar region if you just suture it down. So I don't know if there are actually some guidelines that would say, I don't know, if there is half of centimeters more than that you have to do. No, it's more a rule of thumb. So experience and actually it's also sometimes I would say it also surgeon's preference. So if you're skillful with bony reconstruction, you will always try to reconstruct the bone, even if some of the surgeons would just go for the soft tissue closure, which also works fine. So yeah, I don't know if I answered it, but it's more complicated. Like it's not a rule of thumb. Yeah,
it's more of that. So there's another question we also have. It says, "Good afternoon, Professor. I would like to ask, when is the best time to place the obturator and prosthesis? Should we wait for the granulation tissue formed?"
Yes. So we usually try just to have the granulation cover the bony parts. So it usually takes 14 days, 3 weeks, depends on how it goes. And for that time, we only have the pack inside, and we remove the pack every once a week. And then the obturators are made by the prosthetics. But the problem with the prosthetic is that because of the microvascular reconstruction, all of the old prosthetics, the prosthodontists that were really skillful on doing the obturators, they have to be hollow because otherwise they're really heavy. And all of the older prosthodontists already went into the retirement. And so nowadays with the 3D scanning, it's a little bit easier, but still I don't know if we do 1 or 2 obturators per year. No, I would say 2 per 2 years, or maybe one a year. So we usually close the defects, and the obturators are only left for the rescue when the flap has failed or the patient is not suitable for some kind of reconstruction.
Okay.
But you have to wait so you have the epithelialization done and then go with the final obturator.
Okay, perfect. Thank you. Thank you very much, Doctor. Is there any other questions that you guys have? So far, I think that's it. That's the questions that were in the chat box. Thank you very much, Doctor, for accepting our invitation again and for giving us this wonderful lecture. Thank you. And I am at awe because the amount of information you have given and the time has been a lot, and we can delve into each of the subtopics of what you've like the surgeries and the management, and I hope you can do a follow-up. If again, we would love to do something again that would be available for you, Doctor. And now I'll hand over to my colleague Mariam. For the Congress announcement that's going to happen in Slovenia. So I'll hand over to her.
So thank you so much, Mehi. And I would like to take the opportunity to thank so much Dr. Tadej for your great webinar. I really enjoyed. And as I mentioned in the chat, I faced one of my cases. She was having, it wasn't an oral cancer, but she was a cancer patient. And I can say that she was one of the patients that changed my perspective towards dentistry and what precautions we need to take if she's taking radiotherapy, chemotherapy. So thank you so much for highlighting that topic and opening our eyes as dentistry from all over the world about oral cancer. So we have a full responsibility for treating our patients, and we are the ones who need to, if you are suspecting a weird looking lesion, we need to always refer if you are a general dentist. So thank you so much for that amazing presentation. And I wanted to have the opportunity for since you are from Slovenia, and our upcoming IADS Congress, it will be happening in Slovenia. So I wanted to announce that the registration is open, and we're currently having our early bird registration. So I hope to see everyone. And you saw now the Professor Dr. Dovsak online, but I believe everyone's wanted to meet you in person as well. So stay tuned. Dr. Dovsak, he will be with us as a speaker in our Congress. So hopefully he will give us from his time. So I would like to show our Congress website so they can also have a look for the registration part. Sorry for taking your time, Doctor. So this is our Congress website. As you can see, our Yana shared the link on the chat box. You can open the website, you can look through it. You are all invited for Slovenia. You can see Slovenia, it's part of it, it's love. So I believe it's time to see Ljubljana and enjoy our theme. It will be about building bridges. So we'll be having different topics, different interesting scientific program, lectures, workshops, and of course a social program. It will be my first time to come to Slovenia. So I saw a lot of nature pictures for Slovenia. And of course, the professor would agree with me that it's amazing.
Definitely.
So we are waiting for you guys. This was some pictures from our past congresses, and we can't wait for having the pictures in Slovenia. So waiting for you, and thank you so much, Dr. Dovsak, for really having a very, very amazing webinar. And see you in Slovenia in September.
In Slovenia, although I probably won't make it because I've seen it according to the dates, I'm still in Peru. But nonetheless, I'm coming back on the 1st of September. So if you're going to be in Ljubljana, I'll gladly join you for a beer. Or we might even get some time for the lecture. Nonetheless, we'll talk about that later on. Thank you for having me. It was a pleasure. You really stick to the bloody thing for an hour and a half, so I give you credit. So enjoy, have a nice day, and bye from me. Yeah.
Thank you so much. See you in Slovenia. We'll be having our second scientific day in the 4th of September. So we will have you from the airport. Thank you, guys.
Thank you, everyone. Bye-bye.
Bye-bye.